лечению субарахноидальных пациентов с субарахноидальным кровоизлиянием? Если есть, давайте. Я понимаю, что все устали. Сейчас после этого сделаем перерыв. Татьяна, пожалуйста.
Okay, thank you again for your report. And the question is whether you perform CT perfusion scans routinely in your poor grade subarachnoid hemorrhage, or is it just an optional thing for some patients? So is it a routine or?
Yes, we are doing this on a routine, frequent basis. We are using it after aneurysm treatment. The day after that's either coiling or clipping. So on day 1, we get a CT perfusion scan baseline. There shouldn't be any vasospasm attached. We are implanting a probe either during surgery or the latest after this CT perfusion scan. If we're in doubt, we're using the right forebrain, as usual, the border zone. We are doing another CT perfusion scan in the Hunt test grade 4 and 5 patients who stay on the ventilator, who do not improve after treating hydrocephalus and treating initial treatment on day 4 to 5 and on day 7 to 8. When we perform also CT angiography to see whether there's anything on the major vessels happening. And probably again on day 13, 14, if the patient is still intubated and still is unconscious, to see whether there's any late vasospasm occurring. At least 3 to 4 scans of CT perfusion in a high grade or poor grade, it depends on what you mean, is performed. If the patient improves, I don't think there's a good place to give this amount of radiation in a patient who is talking to us and is understanding and obeying commands. I think this is wasted and it's probably over-treatment. In these patients, I'm also not using these kind of invasive probes. So these are not the good candidates. There's a relationship between harm and risk on the wrong side.
Thank you for your presentation. I have a question. There is limited data about using anticoagulation in non-treated, not treatment patient. How do you manage with this patient in your clinic? What is your opinion?
Very good thing. There's, to sum up, the opinion that aspirin should lower the incidence of subarachnoid hemorrhage in case you have have a patient. So this is for the outpatient. And on the ICU, there's the idea that heparin seems to lessen vasospasm and problems with patients, even if the aneurysm is not yet treated. So far, we are trying to enroll patients with this aspirin thing. The patients we want just to observe the aneurysm and not treat it without subarachnoid hemorrhage in a prospective study. So I have no good answer for that, but it may be an idea. In patients on the ICU with a ruptured aneurysm, which is the main reason why we are treating these kind of patients, we're using heparin only after aneurysm securing, and then quite liberal. So this is the current anticoagulation procedure. We're using unfractioned heparin, normal, not a low molecular weight heparin, which may be an option as well. The guidelines are not very specific about that.
Спасибо за доклад. Когда вы решаете вопрос об ангиографическом лечении после назначения артериальной гипертензии, сроки?
Angiography after subarachnoid hemorrhage and upcoming hypertension. Usually we do an angiography scan when the patient has any clinical indications, see worsening of oxygenation levels going below 20, having a raise of blood pressure unexplained for something else, having some neurologic deterioration with, which is difficult to decide in these poor grade patients. And if we do not have anything, we're using at least the CT angiography at day 7 to 10. The treatment of the aneurysm is usually performed, the decision about treatment, whether coiling or clipping, is based on CT angiography. It seems to be sufficient for most aneurysms with more than 2 millimeter in diameter. the control afterwards, baseline day 1 again, and then over time if something deteriorates on monitoring.
При наличии ангиоспазма первая линия – артериальная гипертензия, затем ангиография, использование баллонной ангиопластики или сосудорасширяющих препаратов. Когда что?
Also a good question without evidence in the literature. Usually the blood pressure rises by itself by a patient with vasospasm. This is a frequent observation. We are using it as first-line treatment. We are not using hypovolemia because I think the studies I showed did show that there's no good help with hypovolemia. Blood pressure, meaning with a systolic blood pressure up to 200 or 220, around that, with cardiac output monitoring, with echocardiography at least once as baseline to see that the heart is capable of doing the blood pressure over time. The angiography, it needs to be ruled out if there's any treatable vasospasm. If it's the major vessels like carotid, MCA1 branch, maybe A1 branch, or basilar artery, usually ballon dilatation. If the patient is symptomatic, if there's just angiovasospasm, the patient is asymptomatic, meaning talking to you in a good condition, you wouldn't do anything. So no prophylactic angioplasty without any intervention, without symptoms in a patient. If the spasm is more peripherally in M2, M3, we use nimodipine with a single shot infusion in the angiography, knowing that the effects may be just limited over the time of infusion and wane off very easily. I used to have, if you read this one paper, I used to do it even prolonged for 1 week, leaving a catheter in place and infusing on the ICU, continuous nimodipine. Well, in this paper we had 10 patients, 3 of them had a good recovery, 3 or 4 of them died, 1 of sepsis, with a catheter being infected probably, so there's inherent risk to that. This kind of therapy is frequently performed, and about 80 to 90%, according to, I think it's World Neurosurgery 2016, to a survey in Northern America and Europe, about 80% of neurointensivists tend to do something with angiography. But the evidence is very poor for either method. And I remember the Vasospasm Conference 2013 in Lucerne, Switzerland, where there was one paper presented. They had a randomized control trial. They diagnosed vasospasm, angiovasospasm, and were about to intervene and randomized whether to intervene or not. The patients being intervened had a much better radiologic result immediately. But then, after 3 months of time, the patients who had no intervention and just conventional treatment with a little bit blood pressure elevation, keeping the patient sedated, taking good general intensive care, had a better outcome on the other side. So the intervention was good for the immediate effect, but the long-term effect on long-term outcome, and this is what counts, whether our relatives get back home, or whether our loved ones are just at home with us again and without any neurologic compromise, were worse in the treated patients. The study was published, never. It was presented 2013 in July in the Vasospasm Conference. I approached the author several times. Yeah, it's pending, a manuscript is in preparation, but the 5 years out now of the finishing the study, I have the doubt that some of the data may not be that fortunate as it was presented in the first run. I have no idea. I have no access to the original data. I see the abstract. You can find it on the internet if you want to, but still we need to analyze what they did and what the problem of the study was, if there was any problem, and it should be repeated with a bigger randomized controlled trial, in my opinion, which is the most rigid way to get evidence for or against that. It may well be that it's helpful, but the current way we are applicating this kind of intervention, either lumentovasti or nimodipine or milrinone or let's say the verapamil or even papaverine, it's used sometimes as well. It's just, well, playing around, but we have no good evidence that you're delivering good medical treatment to the patients. The evidence is too few, so it's out for some randomization, in my opinion. And frankly, I want to prepare this when this is submitted, the lumbar drain stuff, to some of the major journals. I think it's probably the next study I'm going to prepare. So if you're interested in such kind of research, would be invited to participate, of course. Further questions?
Thank you for your interesting presentation and for the interesting discussion. A very difficult question for all of us, not only for you, and very interesting your opinion. Do you have any contraindication for treatment, microsurgical endovascular, of high-grade patient with subarachnoid hemorrhage? I mean, maybe Hanhess 5 or Glasgow Coma scale 3 or point, and something else.
Very good question. When to treat a patient and when to stop treatment? I used to be more pessimistic 5 years, 10 years ago. Nowadays, I would like to suggest to give everybody who seems to be treatable, meaning ICP is under reasonable control, let's say below 30, not with blown pupils, give him a short course of aggressive treatment for at least a few days and up to 14 days to see what's truly happening. But otherwise, we are in the circle of self-fulfilling prophecies. We think a patient is bad and he will probably have a bad outcome because we think that we are withholding treatment or not initiating treatment, and this is a self-fulfilling circle of prophetication. This is not a good idea. I tend to make some agreement even with the relatives which are approaching. Is this 75 years old lady capable of getting back home again? I would like to propose a short aggressive course for 10 to 14 days in most patients with subarachnoid hemorrhage and give them full treatment. Meaning clipping, if possible, yes, as well, also coiling. So there's more on the features of the aneurysm, not on the clinical grade of the patient. If a patient has, let's say, intracranial hemorrhage, MCA aneurysm, it's probably a good candidate for surgery to remove the blood. But if there's no big blood clot, I think coiling may work if the patient is suitable for both methods. It's maybe on decisioning who is available and what method is available. I have no clear preference for that. But a short, aggressive treatment course for a few days to see what's happening, which may be stopped if major infarctions develop, I think is just justified in aged patients. This is a little bit backed up after reading Critical Care Medicine 2015, Lantigua et al. From the New York group, Stephen Mayer's group, a very nice paper. They analyzed this SHOP data, the Subarachnoid Hemorrhage Outcome Project, over 20 years with 1,200 patients inside this database with prospective evaluation and follow-up after 6 months, even after 1 year. And it's amazing to see how these changes of treatment evolved over time. And this is just a learning effect. In the 1990s to 2000, we did not treat Hunter's 5 patients. Now some of them do make a good recovery. But I'm unable to guess upfront which patient that is, to my opinion. And I'm doing this for 20 years now, probably as you as well.
Еще вопросы, коллеги, по терапии вазоспазма, профилактике вазоспазма, хирургические консервативные методы. Если нет, тогда я... Кетован, у вас есть вопросы, как у нейрохирурга? Нет. Хорошо. Стефан, у меня очень такой вопрос. Клоназепам вы упоминали. Ваш опыт, я, насколько знаю, клиника участвовала в трайле про клоназепам, антагонисты эндотелиальных рецепторов. Ваши ощущения и насколько на сегодняшний день оправдано, одобрено использование данного медикамента по лечению вазоспазма?
Clazosentan. Nice trials. There are 3 trials out. The first trial was positive. It was an endothelin antagonist which widened the vessels. It seemed to work on vasospasm. There was significantly less angiographic vasospasm, but the final long-term outcome after 6 months was about equal in both groups. So it seemed to be that in the whole group there was the advantages from the drug taken over by the side effects from the drug. So there was a cancelling out of the effects. If you look at the papers more closely, which I did when, as I told you, I'm preparing the early train manuscript now, they had a mortality of 5%. If you look at the inclusion criteria, it's predominantly good grade patients. Hunt has 1 and 2, 3, and less 4 and 5. Hunt has grade 2 and 1 patients with coiling. Surgery is a little bit worse, probably. This is the reason why the ISA trial was in favor of coiling. Seem not to have that frequent a problem any more than it used to be 20 years ago. So maybe the clazosantan trials had aimed at the wrong population with less risk for vasospasm. There's no good subgroup analysis, even in personal communication with the main author of the clazosantan trials, Locke McDonald's, available with only Hunter's 4 and 5 grade patients. I wonder whether the drug may have some effect in these more high grade patients. This is not to be drawn off the publications, seemingly not from the forest plots, but they were not that as conclusive as I would like have them to be. They are trying now to re-establish another clazosantan trial for angiographic vasospasm, but then I think the target of angiographic vasospasm, which was the main focus of the clazosantan trial, is probably not the appropriate target. Look at the few early drain data you saw before. The angiospasm was not affected, but the outcome was different. The same in the British Nimotop trial. Nimodipine does not affect the angiographic vasospasm of the big vessels, but it leads to a better outcome with less infarction. Maybe vasospasm is not the appropriate target. It's maybe one idea, but otherwise I have no good explanation. But so far, clazosantan, well, it seems to work, but not as good as intended. This is the reason why it's not available anymore. But this is a business decision. This is not a medical decision.
Thank you. Tom?
Thanks again for report. So you are expert of the treatment vasospasm. So I guess. And the question is, so have you any experience in sympathetic ganglion blockage? Still ganglion blockage. So if you have no experience, so what's your attitude to this procedure? Thanks.
Great idea. Great idea. I burned one study, presented some of the data still unpublished on the vasospasm conference in Japan 2015. We did include a stimulator at the ganglion, try to stimulate and get rid of the vasospasm. There were some effects seen, but the cabling was that unstable, so we didn't see a truly lasting effect on the vasospasm. This was 7 patients in 4 centers with established vasospasm where the other things did not work. These were the only patients we were permitted to do this from the IRB, the review boards. Then it may be one idea, but I don't have a clue whether it works truly. This was just a phase 1.5 study. And we need to abandon it prematurely because the company went out of business due to a lack of resources. This was the problem then. But the idea is not completely dead.
Коллеги, еще вопросы есть? Все. По-моему, все истощили все. Уважаемые коллеги, предлагаю поблагодарить Стефана Вольфа за прекрасную